Welcome, everyone. Welcome to our Learn Community Education session. I'm Dee Childers with Life Changes Elder Care Consulting and Vice President for Learn and the Community Education Chair. And today our topic is durable medical equipment options. So Learn is Lifelong Education and Aging Resource Network, and we're an Idaho-based nonprofit organization with a mission to provide community education on aging and caregiving topics. Learn is a leaders network of the Society of Certified Senior Advisors, or the SCSA, and they are an organization that educates and certifies professionals who work with seniors. This content is provided for general information purposes only and not to be considered financial or health advice. Please consult with your legal, financial, healthcare, or other service providers before taking action based on this information. And today I'm very pleased to announce our sponsors. Peggy Farnworth is a retirement coach, and she helps plan for your retirement journey from pre-planning through legacy planning. And her contact information is on the screen at this point, as well as our co-sponsor this session is the Counseling Center. And it's the Counseling Center at Tree City Church, and they are a dedicated professional counseling center designed to help anyone who's struggling with aspects of life. And I'm so pleased our sponsors would allow us to make this training available to all of you free of charge because of their sponsorship, and these are two exceptionally great sponsors, so thank you to them. And today I'm very pleased to introduce our speakers. Primary speaker is Kaitlin Larsen, and Jeanette Angeletti is kind of in the background and will be supporting Kaitlin from afar. Kaitlin Larsen has been with Norco for close to 2 years, and she's worked in different departments and has well-rounded experience working in the durable medical industry. Prior to Norco, Kaitlin worked in the Idaho Department of Corrections. She worked in medical billing and in the medical building, not medical billing, and was also trained as a crisis negotiator. This presented her with keen insights into an awareness of the social and medical needs in our community. So welcome, Kaitlin. Thank you for joining us today. And whoops, that was one too many. So Kaitlin, I'm gonna let you go ahead and share your screen at this point. I'm gonna stop and you're ready to go. And you are on mute, so don't forget to take yourself off mute.
All right, thank you very much for that introduction. I'm really excited to be here. I've been looking forward to this for a while now. Excellent. So yes, I do have Jeanette over to the side of me. She's going to be my little news anchor earpiece, just in case I do come across any questions that I can't answer right away. She's going to be here as a backup and support for me. So if anyone does have any questions, please stop me at any point, or else I am going to be a runaway train and I will keep going.
And you can put them in the chat as well, and Dara and I will keep an eye on those.
Yes, please. All right, so let's just go ahead and start. So first of all, let's talk about what exactly durable medical equipment is. So DME stands for durable medical equipment, and the Social Security Administration describes it as equipment which can withstand repeated use and is primarily used to serve a medical purpose. Now, this medical purpose is generally inside the home, not in a hospital setting. So things you use for living or mobility outside of the hospital. Typically, that is things that can withstand use on a daily, monthly, yearly basis. So hospital beds, wheelchairs, oxygen concentrators, that kind of thing. This isn't disposable equipment that you use once and throw away. Now, we're also going to be talking a lot about insurance coverage, because that is one of the main questions we get here at Norco is, how do I get this covered through my insurance? Well, the big answer is it depends. It depends on what equipment it is you're trying to get covered. It depends on which insurance you have. They all have different guidelines. So we're going to go over the basics of all of them. That's going to be mainly Medicare and Medicaid. If you have any questions about a private insurance or Med Advantage plan, shout out, we'll get your questions answered, or you can just call us and we'll answer anything that you can come up with. So here are some quick insurance abbreviations and things that we can go over before we get started so everyone's on the same page. An RX, of course, is a prescription. A DX is going to be a diagnosis. CN is chart notes, which is another form of documentation from the doctor as well as a prescription. O2 is oxygen. And there's one thing that I really want to emphasize for the rest of this slide is when I use the word covered, that does not mean 100% paid for by your insurance. They're still going to be subject to a deductible or a co-payment, which is usually 20%. That is going to be patient due. So as long as you understand that covered does not mean 100% paid for, we're going to be golden. Now, exactly what chart notes are documentation from the visit with the prescribing physician that wrote the prescription. This is where the doctor can go into detail documenting the reason why the patient needs the equipment that they are prescribing. Because what happens is the doctor writes the prescription for insurance to pay for something, and then insurance goes, do we really need to pay for that? Why don't you go into a little bit more detail and explain why the patient needs it? Chart notes are the place that the physician can do that. And then a capped rental is something that insurances do where it's rented for a certain period of time. And after that period of time, it's considered owned by the patient. Does anyone have any questions on any of this so far before we get into the good stuff?
I think you're good.
All righty, well, let's keep trucking. So let's talk about the first thing, which is going to be wheelchairs and transport chairs. This lady is sitting in what is commonly known as the wheelchair. Now, wheelchairs, everyone knows what they are, what they look like. The big difference between them and another transport chair is the fact that the user can propel themselves using this big, large rail on the side of the wheels. The user can also lock the brakes using this mechanism here. Now, the weight of a wheelchair is around 35 pounds. If you get the lightweight model, it's around 30 pounds, but it's of course more expensive. If you were just to come into the store and purchase this off the floor, it starts at $350, and then it goes up from there depending on how many bells and whistles and gadgets that you want to get on top of it. There are some that have wheel locks in the back. There are some with different kind of leg rests, and of course the price goes up depending on those. Now, for insurance, they're only going to pay for the most standard model. And for Medicare, it's going to be a 13-month capped rental, and Medicaid, it's going to be a 10-month capped rental. In order to get insurance to pay for these guys, we have to have chart notes that state that the chair is needed in the home to perform activities for daily living. An abbreviation for that's going to be MRADL. That's mobility related activities for daily living. That's an acronym that you might see in the chart notes. They must also rule out the ability for the patient to use a walker or cane to complete those same activities. Because of course, insurance, they are a business. They're going to look at those chart notes and orders and say, okay, well, if the patient can use a walker to get around the room and a walker is only going to cost us $60, why would we pay for a $350 piece of equipment? Well, that's why we have to have chart notes that say because they can't use a walker, they need a wheelchair. And then the last thing to point out with insurance coverage is that they're only going to cover one mobility related aiding device every 5 years. So that's something to watch out for when you're trying to get one of these items covered through insurance.
So, Kaitlin, that would include things like the walker, transport chair.
Yes, so that's going to include wheelchairs, walkers, canes, front-wheeled walkers, any type of thing like that. So the other thing that you can get is a transport chair. Now in these guys, it doesn't have the big wheel with the railing on it for the user, so they cannot be self-propelled. they have to have a caregiver or somebody pushing them in order to get around. The patient also can't lock the wheels. The caregiver has to be able to lean over and lock the wheels there. However, they are more lightweight and transportable than your standard wheelchair. So instead of 35 pounds, they weigh around 19 pounds, and they're a little bit cheaper too. They start at the $250 mark rather than the $300. It is very, very difficult to get this item covered by insurance. So it's very rarely done. Most of the time they're going to pay for the wheelchair, but not a transport chair. Now, one thing to look at when you're trying to decide what's best for you is the arms. So most of the time people in wheelchairs have a hard time standing up. They need this spot right here to place their arms down and help push themselves into a standing position. However, if you're going to be trying to roll that patient up to a desk or a table for them to eat, you're going to want arms that have that little cutout there. But of course, it's not going to have that spot there for the patient to help leverage themselves out of the chair. So consider those two options when you're coming in and you're looking for what might be right for you. Any questions at all on transport and wheelchairs?
Yes. Kaitlin, it seems to me that this is one of the more difficult DME equipment to be able to get. And can you comment on that? Why is it so hard to get the justification needed for a wheelchair?
Absolutely. I'm going to have Jeanette tell me if I'm speaking out of turn here. But the reason it's so hard to get covered is because it has to have really good documentation, not only about the patient's need for a wheelchair, it also has to talk about the patient's inability to propel themselves, and it has to talk about the caregiver's ability to propel the patient while they're in the wheelchair, or excuse me, in the transport chair.
Okay, I'm just talking about wheelchairs in general. It seems that there's an inordinate amount of documentation there.
The biggest reason is they have to document the need for wheelchair on the whole.
Right. So the biggest reason is because the doctor needs to document the reason why the patient needs the wheelchair inside the home. Okay. So there have been a couple issues I've run into. I'm not sure exactly which insurance is. It may have been Medicaid, where we needed to have documentation about what the inside of the home looked like. For example, what is the narrowest doorway inside the home? What is the highest threshold inside the home? There's lots of different documentation that has to go on in order for insurance to look at the home, the caregiver, the ability of the patient to go, yes, this wheelchair is right for this patient to use outside of a hospital setting.
Okay. And I think just understanding that it needs to be directly related to an activity of daily living. So that's helpful information.
Absolutely.
Okay. Thank you.
Certainly. All right, we're going to keep moving and going on into hospital beds. Now, when we say hospital beds, I hope nobody's picturing the beds that they have inside the hospitals. This is a much more simplified version, and it looks very similar to something like this. So this is our semi-electric hospital bed. It has two functions that are controlled with a remote. First is going to be raising and lowering the head of the bed, and the second is going to be raising and lowering the foot of the bed. So it turns at those nice, neat angles for the patient to be able to fit snug, just like that. However, in order to make the bed move up and down, that is done manually by a hand crank here on the end of the bed. So that's why it's called semi-electric, because it has some functions that are electric and some functions that are manual. The semi-electric bed, you can rent out of pocket, not having a prescription, for about $170 a month. Or if you have Medicare and we can't get it covered through them for whatever reason, we would just charge you the Medicare allowable. Now, if Medicare does participate in coverage, it's a 13-month capped rental. For Medicaid, it's a 10-month capped rental. And here's we get into those fun chart notes again. They have to state, in order to get it covered, the chart notes have to state that the patient needs an immediate change in position due to the related diagnosis. So the diagnosis that the doctor wrote on the prescription for the bed. They may also state that the patient needs elevation of the head and feet for, again, that same related diagnosis. The bed railing on these guys are easily adjustable into the up or down position, but they are attached to the bed just with a knob, so they're not super stable and they're not meant for the patient to put their full weight on it when transitioning in and out of the bed. It's more of a stabilizer and a safety device to keep the patient from falling during the night.
And Kaitlin, there you can do an upgrade with a power feature that allow to elevate the bed higher and lower, but that is not covered by Medicare.
I am so glad you asked that. I've got a whole slide prepared just for that question.
Excellent.
So yes, there is an upgrade available called the full electric hospital bed, where it does have that remote function to move the bed up and down, and it does not have this manual hand crank on it. These rent out of pocket for $225 a month, and insurance does not cover the full electric bed, but they do cover the semi-electric. So if the Medicare patient, for example, gets a semi-electric bed covered, but that patient wants to upgrade and use the full electric model, they can absolutely do that. It would just be an out-of-pocket enhancement fee, which is typically around $56 a month. Now, Medicaid can possibly cover the entire cost of the full electric hospital bed. It's rarely done, and it does require a prior authorization, but I've seen it happen. It takes some time and some documentation. When that happens, again, it's a 10-month capped rental for the full electric bed. Any questions on those? All right. Let's get into walkers. So we've got two basic kinds of walkers. This couple's using one of each. The lady is using our front-wheeled walker, and the gentleman is using the four-wheeled walker. Are they the same thing? Not really, and not according to insurance either. So let's get into some of the differences. For a front-wheeled walker, it's just our very basic model. They're very transportable, much more so than the four-wheeled walkers. You can get different glide caps for these little back nubs here that are shaped like skis, making it easier to go over thresholds or cracks in the sidewalks. They have a weight capacity of 300 pounds. They only weigh 8.5 pounds. And these back legs fold inward based on this hinge here. So they do fold flat. They are height adjustable, and they'll fit patients between 5'4" to 6'2". When you're fitting a walker, you want to make sure that if your hands are hanging at your side, the handle of the walker is hitting right where your wrist is when your arms are hanging down. Any higher and you're going to be a fall risk, any lower and you're going to be stooping over it. Nobody wants that. If you were just to purchase this, they're around $65. Medicare and Medicaid do purchase them. However, if the patient is over 300 pounds, that is a heavy duty or a bariatric front wheeled walker, that's going to be a rental item. In order to get these covered, we just need chart notes from that face-to-face visit with the physician discussing the need for a walker.
So two questions there. What if you have someone that's taller than 6 feet 2 inches? And two, is it still face-to-face even with where we've kind of evolved with telemedicine?
So as far as face-to-face with telemedicine, last I heard, and this is a rumor and not exactly my realm of expertise, a telehealth visit is not considered face-to-face for Medicare and Medicaid. I would definitely check with your insurance provider on that one, but After the wave of COVID hit, they pretty much said, nope, face-to-face means my face and your face. And as far as what to do when a patient is over 6'2", we do have some 4-wheeled walkers, right, Jeanette?
We have wheels that you can exchange, legs that you can exchange on there that will make that a taller walker.
Gotcha. So we do have some legs that you can put on just that standard walker to heighten that and extend it and make it taller for those individuals.
Okay. And that's a purchase item, I would assume.
They are purchased unless they're the heavy duty version, in which case they're rentals through insurance.
Thank you.
It's still acceptable right now, but it's supposed to be going.
Gotcha. And I'm being told by my little earpiece that the telehealth conferences, that rule is in talks, and that might be going away to the point where the telehealth conferences are considered a face-to-face. It's not where we're at right now, but it's good news for the future.
Okay. Excellent. Thank you.
That's okay. All right, so we're going to talk about 4-wheeled walkers. So these have, of course, the seat, and it has storage underneath the seat. It has locking brakes that connect to the rear wheels. And these locking brakes are very important because the main point of a 4-wheeled walker is to give the patient a place to sit down that's readily available for when they get out of breath when they're using the walker. Definitely make sure that those walker brakes are engaged before you go to sit down or stand up so that it doesn't slide out from underneath you. These also have a 300-pound weight capacity. They do weigh more than the front-wheeled walker. They're 17 pounds. And their standard sizes fit folks between 5'3" and 6'1". Again, we do have models that can accommodate those taller sizes. Getting them covered through insurance gets kind of tricky, but we're here to help you with that. If you were just to come purchase one of these guys, depending on how fancy you want to get, it's going to be between $100 to $300, somewhere in there. For Medicare and Medicaid, these are purchase items, unless you're getting the heavy duty model, in which case it's a rental. Deluxe models like this Nova Star roller here are going to have an out-of-pocket enhancement fee because Medicare is only going to pay us one flat allowable fee for the walker. If the patient says, oh no, the wheels are a little small, I don't like the aluminum frame, I like the seat on this one, I want to get this one, you can absolutely do that. But just like the full electric bed, there is going to be an out-of-pocket enhancement fee for that model. Now, Medicaid, we cannot charge an enhancement fee for. So if you're a Medicaid patient and you would like a 4-wheeled walker, we're going to have to stick with this basic model right here. That's per their requirements. Any questions?
Kaitlin, I also think of it as the 4-wheel walker with brakes as a safety feature, that some people are great fall risks. So that's my interpretation of part of the difference between a 4-wheel and a 2-wheel. Is that legitimate, or am I just kind of making stuff up?
It's not illegitimate at all. 4-wheeled walkers are absolutely going to be safer for people that are fall risks. Or excuse me, no. Front-wheeled walkers are going to be safer for people that are fall risk. Would you like to elaborate on that?
Front-wheel walkers are just safer because they don't move as fast. Anytime you give somebody that 4-wheel walker, they want to be able to control the brakes to be able to stop. And when you get somebody who's really feeble, they don't have that ability.
Gotcha. That makes sense. So just to reiterate, you probably can't hear her very well. When you get a patient that is low dexterity and high fall risk, they are going to put a lot of weight on that 4-wheeled walker. And if they don't have the manual dexterity to hit those brakes, that's going to cause more of a fall risk. Now with these front-wheeled walkers, just putting your weight on there means that you are going to stop, period. There's very minimal dexterity there. And in order to actually propel yourself with that front-wheeled walker, There has to be a little bit of picking that walker up and shuffling it forward. That's going to put you a little off kilter just for a second, but the instant that the patient starts leaning one way, it stabilizes itself and makes it a lot safer that way.
Thank you.
Absolutely. All right, let's get into bathroom aids. There's a few different categories here, and this is where Medicare and Medicaid kind of diverge off of each other a little bit. So there's two kinds of shower chairs. There's just your basic shower chair that goes inside the tub, which you can sit on it. And then you have your transfer bench. So a shower chair can have a back or armrests on it. And a transfer bench, again, can have a back or armrest. Now, while this guy goes inside of the tub itself, the transfer bench has two legs that are on the outside of the tub and two legs that are on the inside. And the point of that is for the patient to be able to sit down, throw their legs over the end of the bathtub, and then scoot over into the shower. So it depends on what your home situation is based on what's going to be safer for you. A shower chair is a great option if you have a walk-in shower and you don't have that lip to try and raise a leg over. If you do and you are more of a fall risk, I would definitely suggest a transfer bench over the shower chair in that case, because it'll help you with transitioning into the tub. Prices range on those. Transfer benches are more expensive, $150 to $200, whereas the shower chair is going to be $60 to $100. And again, that's dependent on how fancy you want to get with the back and the arms and the rest of that. So for insurance, Medicare absolutely will not cover any kind of bathroom aid. And Medicaid has one exception to that, in which they'll participate for the coverage for a shower chair. But again, it's only going to be the most basic option. So options are limited on those. Any questions on those two? All right, pretty straightforward. Moving on to a couple more bathroom aids. You have your toilet seat risers and your commode. Now, a toilet seat riser, the point of it is to increase the height of the seat, making it easier and safer for the user to both sit down and stand up because it's not so far of a distance and it's a lot better on your knees. In fact, they're a really good option to have after a knee or a hip surgery. However, if it is a hip surgery, I would not recommend getting a toilet seat riser with arms on it just because you don't want it bumping into that. We do sell some freestanding handles that can go around the toilet. They're not attached to the seat at all. So if you need help lifting yourself up that way, that's a good option to have as well. As far as commodes, pretty self-explanatory. They're for patients that are pretty much confined to one room, and it's very difficult for them to use the facilities inside the house. Now, commodes can be covered through Medicare or Medicaid as a purchase item. However, the chart notes must indicate pretty much exactly what I said, which is the patient is confined to one room, or there is no facility inside the house, or the facilities are on a separate level and the patient can't make it up the stairs. So there's a couple different things the chart notes can say to indicate that the patient needs a commode.
Okay.
Questions on those? No? Okay. All right, let's get into oxygen. This is probably the most in-depth course that we're going to talk about. So if you don't use oxygen, be patient with me. We're going to get into it. Now, oxygen insurance coverages. If you're not interested in it, go get a glass of water, get a drink, because we're going to talk about just a little bit here. Now, in order to get oxygen covered through insurance, the number one thing that has to be done is testing. So the first thing you do is you go into the doctor's office and you sit in a chair and you put that oximetry test on, and the doctor measures your oxygen saturation. If that saturation is 88% or lower, you qualify for oxygen. You don't have to do any additional testing. Daytime, nighttime, you can have it. However, if you're sitting on room air at rest and your saturation level is above 88%, we need to do some additional testing. So the doctor will do what is called a walk test, where they'll have you wear the oximeter without oxygen and walk up and down a little bit. If your saturation is lower or equal to 88%, that's great. Next step is they do that walk test while you're using oxygen. And all we need to see is that while exercising on oxygen, there was an improvement from that 88% or lower saturation when you weren't on oxygen. That'll get you qualified for oxygen while you're up and moving about and at night. If you just need oxygen at night, you do what is called an overnight oximetry test. So your saturation needs to be equal to or 88% for 5 minutes during a full night's rest. And it's just this little oximeter that you wear on your finger throughout the night. That's only going to qualify you for nocturnal oxygen, not portable or daytime oxygen. And if you look at your handouts or on the Learn website, I do have a full, really in-depth guide as to how to get oxygen testing and insurance coverage done. So take a look at that if you need more information. Questions so far? Okay, I'm going to keep going to the other side. Oxygen is considered a drug by the FDA, so we absolutely have to have a prescription in order to dispense it. That prescription has to have a diagnosis and a liter flow on it. Generally, it's 2 liters per minute. It can go up or down depending on the needs of the patient, of course. If the equipment is a portable oxygen concentrator or POC, the prescription has to state pulse dose approved. And we'll get into the differences between continuous and pulse dose. The chart notes, those fun chart notes again, have to document the need for oxygen due to a heart or lung condition. The prescription or the chart notes have to say alternative treatment measures have been tried and deemed ineffective. That's also on that guide that I handed out to you. As long as that's somewhere, Medicare and Medicaid are going to be happy. Now, for billing those guys, they are not considered a capped rental through Medicare and Medicaid. Instead, it's a 5-year contracted rental cycle where we can bill Medicare and Medicaid for the first 3 years. And then the next 2 years, it goes into a maintenance phase where we can't bill, but we still provide maintenance and tubing and tanks and anything else the patient needs for those 2 years. After that 5-year period, we can start that whole billing cycle over again. How much fun is this? Are we good? Any questions at all? Okay.
So quick question, one of the things that we know we've seen locally in the United States as well as in other countries, that if the power goes out, because these are other than the POC, which still is just done by a battery, what's the backup plan if somebody's on a power-based oxygen provider?
Gotcha. So typically, if the patient is just on your standard concentrator, their backup in case of a power outage is going to be oxygen cylinders or those gaseous tanks. If the patient is using liquid oxygen, which we'll get into, and I'll show you all these different kinds of guys, then the liquid oxygen reservoir does not need power, and they can use that in case of a power outage.
And is that something that's automatically provided, or does the patient or patient's advocate need to request these additional tanks, and are they covered?
If the patient is just on nocturnal oxygen, it's typically not covered and it has to be asked for. If the patient's on daytime and nocturnal oxygen, the backup or the portable oxygen is already provided and it doesn't have to be requested.
Thank you.
Absolutely. So let's get into what some of this equipment looks like. Here's your typical oxygen concentrator. You can use this either when you're sleeping or when you're just inside your home watching TV or reading. This runs off of electricity, like you were saying. You plug it into an outlet and it generates oxygen from the air around it. And then it outputs a very concentrated, hence concentrator, form of oxygen. It's our basic model here. This is the Philips Everflow. It can put out a liter flow from 1 to 5. We do have higher flow concentrators that can go up to 10 liters a minute. They are scheduled to be serviced once a year. Our people take care of that and keep track of that. Now, I get a lot of questions about how loud they are. The Philips Everflow is pretty quiet. It runs at 45 decibels, which is about quiet home noise. So we're talking refrigerator, dishwasher levels. So a whisper is 30 decibels and a normal conversation volume is 60. So it's right in between there. If the noise is bothersome to you, there is an option to get longer oxygen tubing and put that concentrator in a different room. As long as it's well ventilated, you should be able to get the same amount of oxygen, no problem. And questions on concentrators? Okay. The next option you can get for stationary oxygen is going to be your liquid oxygen. Now, liquid oxygen is exactly what it sounds. It's oxygen instead of in a gaseous state, it's in a liquid state. And we get it that way by freezing oxygen until it gets to negative 361.82 degrees Fahrenheit. That's the freezing point of oxygen. Why would we want to do that? Well, because when oxygen's in a liquid state, it's much denser and more compact, meaning it's easier to store and it's going to last longer than it would in just its gaseous state per, square inch of storage. Now, these liquid reservoirs do not use electricity. It automatically gets warmed up through these coils and then dispensed to the user, once again, in a gaseous state. It also, if you qualify for portable oxygen, you can get these liquid oxygen portable units, which you can take and fill right off the top of the reservoir. It does take a little bit of strength to hold that portable unit down as it's filling, but that liquid oxygen bubbles up, fills the portable unit. You can then pop the portable off and you've got a few hours worth of oxygen that's ready to go. And they are quite long lasting for their size. On a continuous flow of 2 liters a minute, a full portable unit, say this guy here is the bigger one, it's going to last between 6 and 8 hours. And it's pretty light. It weighs, 5.5 to 8.7 pounds, depending on the model. The reservoirs themselves, this big one here is our standard model. It's the 46 liter one. On a liter flow of 2, it's going to last nearly 14 days. Now, the one thing to keep in mind with liquid oxygen is because it doesn't use electricity, it does have to get refilled by typically liquid oxygen delivery drivers. So you would get set up once or once every other week for our drivers to come out, fill your reservoir, put it back for you, and then you're good to go for another week or 2. Questions on the liquid?
Does insurance pay for liquid oxygen?
They do, yes. However, it is considered a change in modality from gaseous oxygen. So if insurance covers the concentrator and portable unit, we just need an updated prescription from the physician stating that a patient would like to go on liquid oxygen. We'll swap out the concentrator for the reservoir. We'll swap out the tanks for the portable unit, and it's the exact same allowable through insurance.
Thank you.
Absolutely. All right. Speaking of portable oxygen, there is all sorts of options when it comes to that. So the first option is, of course, going to be those oxygen cylinders that we talked about. This is also going to be your backups just in case the power goes out. We'll give you a bunch of these to use. So these tanks are filled with gaseous oxygen. They come in different sizes. This tallest one here is the E tank. That's the one that you'll see people pulling behind in carts. Most hospitals use this size. And we have an option that's even smaller than this guy called the M6 tank. It's about the size of a wine bottle. It's not very big at all, but it's very, very light. Instead of filling these tanks, what we do is we provide the patients with full oxygen cylinders and we take their empty ones away. So it's not a physical fill, it's more like an exchange. Now, as far as insurance goes, we bill insurance for this regulator, which goes on top of the tanks, because this is what is considered the DME, the durable medical equipment. The tanks are reusable, right? So the tanks are just included with the rental of the regulator. Now, when you're looking at how long these last, it depends on if you're on a continuous flow or a pulse dose flow. So a continuous flow is just when it's continuously putting out that constant stream of oxygen. A pulse dose or on demand is when the unit detects the user breathing in and it delivers a puff of oxygen at that moment. This means that it can make your oxygen last longer, right? Because it's not putting it out continuously, just when it's needed. So if you were looking at this large E tank on a liter flow of 2 continuously, it's going to last about 4 hours. But if that same user is on a pulse dose, it would last nearly 17 hours. One thing I do want to mention, though, is pulse dose is not recommended for while you're sleeping. So this is not going to be something that you can turn on pulse dose and go to sleep with, because you breathe different when you're sleeping and it messes up that radar and it doesn't necessarily deliver that puff of oxygen. So just keep that in mind. For your M6 tank, which is much, much lighter, about 3 pounds, on a 2 liter a minute pulse dose, it'll last 4 hours. On a continuous flow, it will last 1. Anybody have questions on portable oxygen tanks?
So is it a fair assessment to say if you're on twice, 2 times the 2 liters a minute, that it's only going to last 30 minutes, or is it stepped down differently?
No, that's pretty accurate. So on an M6 tank, a continuous liter flow of 4 would last you about half an hour. And on an E tank, a continuous flow of 4 would last you about 2. So that math checks out.
Thank you.
Mm-hmm. Now, the other thing you can get is very, very popular at the moment, but there are some limitations. It's these portable oxygen concentrators. You've probably seen the commercials for the Inogen. These are not that brand, but they're comparable. So they work exactly like a stationary concentrator where you can plug them into the wall and they generate their own oxygen. But these have a chargeable battery. So you can unplug it from the wall and take it, go do your shopping and walk around while it's still putting out that flow of oxygen. Now, these here are unable to run a continuous flow. They are pulse dose units only, which is why, looking back to that slide a few slides ago, it said the prescription has to have pulse dose approved, because some patients are unable to tolerate pulse dose. They have to have that continuous flow of oxygen. Those patients would not be suitable for these concentrators, so it has to be on that prescription. Due to the chip shortage and the shipping shortage and all the other shortages, we do have a limited availability of these. So if you do get a prescription one, you're probably going to be on a wait list. It's been getting better. We're only looking at about 4 weeks for one of these smaller portable oxygen concentrators right now. However, remember that 5-year billing cycle we talked about with oxygen? If a patient gets a concentrator and we bill for that for 2.5 years, and we've only got 6 more months that we can bill, the patient cannot switch to a portable oxygen concentrator at that point because we'll only get 6 months billing out of that. So if the patient wants to run through insurance, we're going to have to wait another 2.5 years before we can restart that billing cycle and bill for the portable oxygen concentrator. But there is good news. There is a bright light here. Because if you see on a liter flow of 2, which is pulse dose, a fully charged portable oxygen concentrator will last 3 to 4 hours, and they weigh 5 to 7 pounds, depending on how big the battery is, right? But if you look back here to that small wine bottle M6 sized tank, on a pulse dose flow of 2 liters a minute, it'll last you 4 hours, and it weighs almost half of what the portable oxygen concentrator does. So if you can get a pulse dose approval from your physician and you're not able to get a portable oxygen concentrator, tanks are a very viable alternative that we can get for you.
So Kaitlin, you mentioned switch, and when I think about it with clients, it's been an addition. So when leaving the home for whatever reason, so if it's in addition, is it still covered if it meets that more than 1 year or less than 1 year into a 5-year cycle?
So it wouldn't, because insurance will only pay for one portable unit at a time. They consider these oxygen tanks a portable unit. They consider the POC, or the portable oxygen concentrator, a portable unit. So if the patient started with the tanks, the oxygen cylinders as their portable unit, and they're very deep into their billing cycle, the portable oxygen concentrator is much more expensive. While insurance, they say they will allow it, but we don't get any additional reimbursement from them for providing the portable oxygen concentrator.
So what if they're on the concentrator instead of the tanks?
Oh, the concentrator is going to be their stationary unit. So there's 2 types. You've got your stationary oxygen, which you can use at the home. Insurance will pay for one of those, either a reservoir or concentrator.
Okay.
And then you've got your portable oxygen, which is what you use for out and about, and insurance will only pay for one of those.
Okay.
So you got your 2 options there.
Thank you for that.
Absolutely. Sorry. I will put that in my notes to explain it better next time. Any other questions on stationary versus portable oxygen? Okay. Another big thing that we do is CPAPs and CPAP supplies. So CPAP machines, I'm not going to get into BiPAP or VPAP or any of the other crazy stuff. Straight CPAP machines are the most common type of machine, and they are used specifically to treat obstructive sleep apnea, or OSA. Stock is limited. If you are in the CPAP world and you're trying to get a machine, you already know the struggles about how hard it is to actually physically get the machine because there is a wait list for them. But the news is getting better. Instead of the 4 to 6 month wait list, we're looking at a 4 to 8 week wait list right now. So we're coming through the fog, and we're going to be okay on the other side. Hopefully 2023, we won't have any other wait lists. CPAP is another thing that we have to have a prescription in order to dispense it. If you were just to purchase it out of pocket, depending on the model, it's going to be somewhere between $800 and $1,200. These are another capped rental item. So instead of that 5-year cycle, these are the capped rental cycle. For Medicare, it's 13 months. For Medicaid, it's 10 months. Now let's talk about insurance coverage. In order for insurance to say, okay, yeah, we'll help pay for a CPAP machine, the chart notes have to have testing done that's either done in an in-lab or at-home sleep study. In either one of those, the sleep lab is going to generate an AHI score. That's a apnea-hypopnea index, or an REI score. That's done by the in-home sleep study. So you have to have one of those two done, and it has to be in a qualifying range in order for insurance to participate with the CPAP. Now, after that's done, we've got it covered. You got your CPAP after waiting for 2 months. We're still not done with getting insurance to pay for it. You have to do what is called compliance, which is where insurance says, well, if you're not going to use the CPAP, then we're not going to pay for it. So we got to make sure you're using the CPAP. So how you meet compliance, and if you have OSA and you're using your CPAP, it's pretty simple. You have to wear your CPAP for 4 hours a night for 70% of a consecutive 30 days out of the first 90 days. How's that for criteria? So it's going to look at the first 3 months that you had your CPAP. It's going to pick a consecutive 30 out of those 90 days. And you have to have worn that CPAP for 4 hours a night for 70% of those 30 days. Please tell me that makes sense.
From my perspective, it does.
Okay.
Any questions on that one?
I actually have a question on that one. Does it get tested again? Do they ever test that time again?
So if compliance isn't met within that first 90 days, we have to start that process over again, which means we need a new sleep study done, new prescription, new chart notes.
But once you've achieved compliance, you're assumed compliant.
Yes, once you've achieved compliance and you keep that CPAP for the rest of your 13-month cycle, insurance is good. They'll pay for the rest of that 13 months.
Okay, thank you.
Absolutely. Another thing about CPAP machines is it takes some getting used to. So there's some comfort settings that the patient can do, and there's some comfort settings that have to be done by a physician. First is going to be pressure. So in order to get your pressure changed, that has to come from a physician. However, there is a comfort setting called a ramp up time on most CPAP machines, which is where when you first fall asleep, it'll give you a lower pressure. And then after you fall asleep, it'll slowly ramp that pressure up to the point where you're already asleep. You don't really notice it, and now it's doing its job.
And
So, oh yes, please.
can you speak just a little bit about the humidifier and the heated tube?
Right. So all of these units do come with a humidifier, which it works just like it sounds. It kind of moisturizes the air as it goes in, so you don't wake up with a really sore and dry throat. And then you can adjust the humidity on those humidifiers. And that's done by yourself on the CPAP machine. You don't need to call your physician to change any of those. Another comfort measure is that heated tubing. Not every machine has the ability to have a heated tubing. For example, that React Medical Luna 2 that just came out, it doesn't have the heated tube, which means the air that's getting delivered to you is going to be a little bit colder, and a lot of patients find that slightly more uncomfortable. So you do want to pay attention to what CPAP machine you're getting. Because as you can see here, if this Luna 2 doesn't have a heated tube, but it does have a cellular modem. Now, the point of the modem is so that we can upload your compliancy scores to show whether you're compliant or not. And it's all done over the internet. You don't have to bring your machine into the store for us to get a reading off of it. So it's really what is more important to you. If you'd rather have the heated tube and you're not too worried about your compliancy, the AirSense 10 is a good option for you. If you don't want to come into the store, you live out in the where it's really difficult for you to come in and you don't care so much about the heated tubing, the Luna 2 is a better option for you. These G3s, as you can see, they have everything, but there is a longer waiting list for those. I'm not terribly well versed on the other differences between these. I'm not a respiratory therapist, but that is the basics of what I know.
And do you have like a schedule of how often the mask should be changed, the hosing, the tubing between the concentrator, the CPAP?
Absolutely. So for the concentrator, it's more of a rule of thumb. I have some patients that want all of their tubing swapped out every week. I have some where, they can wear it for months on end, but you shouldn't. Generally, we advise patients to only use their cannulas until they start getting stiff and yellow. That's when you want to throw that out and get a new one. But I definitely wouldn't recommend using the same cannula and tubing for more than a month.
Okay. And what about masks for the CPAP?
For masks for the CPAP, there is a schedule on those that most insurances follow, and it goes off of this chart here.
Nice.
So when it comes to CPAP supplies, there's basically two different kinds. There's supplies that are very mask specific, depending on whether you're full face, nasal, brand, all the rest of that. And then there's supplies that are CPAP machine specific. So filters and tubing and humidifiers are going to fit one brand of machine, but not any other. So when it comes to insurance participation, after you've met your compliance and they're paying for your CPAP, they'll continue to pay for these supplies as long as we have a 1-year renewal of documentation every year with a face-to-face visit with the physician talking about the continued need for CPAP. So this is how it all breaks down. Medicare allows a 3-month supply at a time, but Cigna and Medicaid allows a 1-month supply only. So the frame is going to be this hard plastic guy that's on the front of the CPAP. It's going to include, the actual frame of the unit, and it includes one cushion and the smaller tube that connects to the hopefully heated humidifier tube. Insurance will allow one of those every 3 months. So for Medicare, your 3-month supply, you can get one of those every 3 months. For Cigna and Medicaid, you have to wait and get your other supplies and then come in and get your frame. The cushions are going to be this one that goes right up against your face. It's going to be either silicone or like a memory foam, depending on your preference. For nasal cushions, you can get 2 per month. For a full face, you can get 1 per month. So the headgear is what goes on behind it. That is considered a longer lasting supply. So that guy is just going to be a 6-month supply. Same with the humidifier chamber. That's going to be once every 6 months. So that is the mask specific supplies. Then there are the machine specific supplies. So you have the tubing, of course. We talked about the heated versus non-heated. And then there are also filters, which are CPAP machine specific. There are the disposable filters and then the reusable ones. The disposable filters, you can get once every month. They come in a pack of 2, so really you can get 2 per month. And then you can get 1 reusable filter every 6 months. And then the heated tubing is once every, oh, I just saw it here, 3 months, right? Yes, once every 3 months.
And Krista has just left us a note that from the Idaho Assistive Technology Project that they have low interest financing programs to help people finance their technology that insurance doesn't cover, and could be also used to help with co-pays beyond insurance. So a $500 minimum and a $10,000 max at the moment. And
Wow.
in the notes, she leaves the website for the Idaho Technology Org to get finance or loans there. So.
Fantastic. I'm definitely going to look into that. That's a great resource. Thank you very much.
Yes, and she also leaves her email as well as her phone number there. So those are good notes to take.
Fantastic.
Thank you.
Any other questions on CPAPs or supplies? All right, we are almost done, folks. I've just got a few miscellaneous items to throw out there. If you've got questions on anything I haven't talked about, there'll be time for you to ask me about those at the end. Let me just get through a few of these. So first off, we've got Hoyer patient lifts. Hoyer is technically a brand. It's like Band-Aid, you know, so it's not an actual machinery, but it does this patient lift here. They're used mainly by the caregiver for transferring the patient. We do have these as a rental for $110 a month. They have the same capped rental period with Medicare and Medicaid, 13 and 10 months respectively. In order to get one of these covered through insurance, chart notes have to document that the patient would otherwise be confined to the bed if they did not have access to a Hoyer lift. And they're very handy in certain situations. As you can see, this doodad basically goes over the patient with the sling inside of it. You slip the patient inside the sling, put the slings up on the hooks at the top here, and then you can use this pneumatic handle to pump and raise the patient up. And it does not take a lot of strength to use that pump. You can also adjust the width of the legs down here, narrower to get through doors or wider for more stability as well. Questions on, oh, and yes, it does come with one type of sling. This is the basic sling that it comes with, but you can also get mesh slings to help the patient for bathing, or commode slings to help the patient for getting to the commode or the facilities in the room. Questions on those?
I was not aware of those alternative slings, so thank you for that.
Absolutely. All right. Another very popular item we have is lift chairs. They are basically a very fancy electric recliner that can tilt up to help the user get into a standing position. They have many different type of options depending on how fancy you want to get. Different fabrics, functions. We've got some that have lumbar support and head support, even heated and massaging options. So with all those options, cost is going to vary quite a bit. They start on the lower end at $900 for the units that just recline and stand up. And you can go all the way up to a $3,500 chair if you want the Breeza fabric, the heat and massage, all the rest of that. Lift chairs are very rarely covered by insurance. And when they are, we'll talk about how to get it covered. When they are, insurance is only going to pay for the lifting mechanism of the chair because they don't consider furniture to be a necessary item. So they just pay for the one mechanic that helps the patient get into a lifting position, which takes about $327 off the cost of the chair. Everything else is going to be patient due. In order to get that $327, we need to have chart notes that indicates a diagnosis of a neurological disorder, something like Parkinson's, multiple sclerosis, or severe arthritis of the hip or knees. Chart notes also have to state that the patient can't get out of any chair in the home without assistance, but once they're standing, the patient is able to ambulate. You can see why it's very difficult to get insurance to cover those for so many minutiae when it comes to chart notes.
But that's very helpful. I didn't realize insurance would cover any of it.
Yeah, absolutely. Any questions on those? Okay. Last quick thing I wanted to talk about. Oh, I need to be able to get rid of this. Sorry, folks. There. An alternating pressure pad is a pad that comes with a pump that alternates air between different cells inside the pad. So what this is used for is for patients that are very bed confined and they have pressure sores or are at risk for pressure sores. Alternating the different spots of pressure on that patient helps alleviate some of that risk. This is a less expensive alternative to a low air loss mattress, which functions the same way, but instead of an overlay, it's a full mattress. Low air loss mattresses are very difficult to get covered through insurance, so this is a good alternative. The overlay, so the actual pad itself, is a purchase item, and then this pump, which goes on the end of the bed, is going to be a rental. So the pad is a one-time purchase of $50, and then the monthly rental for the pump is $36. Any questions on alternating pressure pads?
Great resource.
Okay. And that brings us to the end. If you have any kind of DME that you're curious about, now's the time to ask. Does anyone have any questions at all?
So are there other types of DME that are covered by insurance, or is it situational, or is this the general core Medicare covered or insurance covered DME?
This is very, very general. If you've memorized this entire presentation, you know about 10% of what is possible. There are rollabout knee scooters, which is a crutch substitute. That is a rental that you can get covered through some insurances. Medicare doesn't like to pay for those, but Medicaid and private insurances do. What other DME is there, Jeanette? Absolutely. There's all sorts of not exactly durable medical equipment, but supplies that are needed, such as incontinence supplies, urological supplies, ostomy supplies. We don't do wound care anymore. We don't do compression socks anymore, or nutrition. Let's see. But those you can get covered by insurance, those basic kind of resupply orders.
Right. So other medical supplies, but not considered DME.
Precisely, yes.
Gotcha. Thank you. Other questions from anybody?
Is there like a list that would be available at some point, Kaitlin, that could cover the items that you were just mentioning, just, you know, as a, hey, check with your insurance if they cover it kind of list?
Oh boy. So we have a whole department that works specifically on looking at the type of equipment and the type of insurance. And there's all sorts of different kinds of guidelines and everything. They have basically a cheat sheet or a guide that they use that is dozens of pages long and hundreds of Excel cells long. So to answer your question, it exists, yes, but is it likely useful? Probably not. It's probably easier just to call up your insurance company and say, hey, what do you know about oxygen concentrators? What does it take for those?
Okay, thank you.
Absolutely.
Well, or to call Norco, because Norco customer service has been very helpful, and so they know the background, the questions to ask, and how to work within the system. So
Absolutely. And if any of you have any questions, if you call into Norco, just the main number, and you press option number 6, that'll get you to my fantastic customer service team. Jeanette's very knowledgeable, but she is able to answer all your questions if you call that. Or you can just ask for me, Kaitlin Larsen. If I don't answer, leave me a voicemail. I'll get back to you. We try to be as helpful as possible.
perfect. Wonderful. Any other questions, comments? Well, Kaitlin, thank you for an excellent presentation. I've been doing this work as a care manager for 10 years and I learned things today. So very helpful. Kaitlin and Jeanette in the background, thank you immensely for being here and doing such an excellent presentation for us today on the durable medical equipment. Greatly appreciate you and all of the things that Norco does to support the community along the lines of health and aging, your excellent partners. I would also like to thank our sponsors today, Peggy Farnworth, Retirement Coach, the Boise Retirement Coach, and the Counseling Center. And if you will receive an invitation to join our mailing list, if you're not already on it, you must confirm the subscription. We don't ever just sign somebody up, and we'll let you know about the upcoming free education that we have that's on the schedule. If you don't receive that email in the next few days, check your junk mail folder for that. And here is the schedule of our upcoming events. We're going to do something a little different in 2023. All of our sessions are not going to be scheduled live. We will do some live ones, but we're really focusing on the 100 videos that we already have that are on demand in our online video library on our website, learnidaho.com or .org. So we look forward to seeing you. Be sure and check your email for our information coming up on Learn Idaho. And I wish each of you a happy and safe holiday season. Stay warm and we'll see you soon. Thanks so much.